Welcome to Prism Rounds, where we break down one study at a time. This is for education only and not medical advice. I want you to picture a scenario, and it's a scenario that every single person listening to this has been in probably more times than they can even count.
Oh, yeah.
It's 2 in the morning, the department is loud, it's chaotic, and you are standing at the bedside of a patient who is trying very, very hard to die.
The classic 2.0 AM septic shock. It's really the crucible of critical care, isn't it?
It is. It's early septic shock. You've done the initial scramble, you've gotten the large bore access, you've slammed in the 30 cc's per kilo of crystalloid because, well, the guidelines told you to do it.
The bundle is done, the box is checked.
Exactly. The broad spectrum antibiotics are hanging, and despite all of that, the pressure is soft, so the norepinephrine is running.
And you've titrated the pressors, you've got the MAP to 65, the monitor looks okay.
A monitor looks great.
Yeah.
MAP is 65, heart rate is maybe 110, maybe 115, but then you do something crazy. You actually look at the patient.
You lift the sheet.
You lift the sheet. And the knees are mottled, the toes are cold, and then the lactate comes back from the lab, and it took, 45 minutes to get that result, and it's 4.5. And it hasn't budged from the initial draw.
This is the moment. This is the fog of war in resuscitation. You have fixed the numbers on the screen, but you have not fixed the patient.
There really is. And this is the moment where the team starts arguing. You have one person saying, the tank is clearly empty, look at the lactate, give more fluid.
And then someone else is saying, are you crazy? You're going to drown their lungs? Just turn up the pressors.
Right. And then there's always someone else shouting about checking an SCVO2 or doing a passive leg raise or, some other maneuver.
It's paralysis by analysis. Or sometimes it's just chaotic activity.
Right.
We know deep down that every hour of this state of tissue hypoperfusion is killing cells. We are fighting the clock.
We are absolutely fighting the clock.
But we don't actually know if the treatment we're giving that next liter of saline is fixing the problem or if it's actually making it worse. We're guessing.
So what if the answer wasn't on the monitor? What if the answer wasn't in a blood gas that takes an hour to process? What if the answer was literally right at your fingertips?
That is the entire premise of the study we are covering today. It asks a really fundamental question. Can a simple bedside physical exam, finding the capillary refill time beat, the standard of care in guiding us through that fog?
Today, we are doing the deep dive into Andromeda-SHOCK 2.
This is the big one, the sequel. It's been anticipated for years.
The title is a mouthful, let's be honest. Capillary refill, time-targeted, personalized hemodynamic resuscitation versus usual care. But behind that title is a potential paradigm shift in how we manage shock.
It really is. It essentially asks, can we use capillary refill time CRT, not just as a sign that the patient is sick, but as the thermostat for the entire resuscitation?
The thermostat, I like that.
Yeah, can we build a whole protocol around normalizing that one physical exam finding?
Before we get into the results, and there are some really, really nuanced results here that we need to unpack carefully, let's get the study details on the table. Pull up the ID card for us.
Right. The trial is ANDROMEDA-SHOCK 2. You've got to make sure you say 2, not 2. This was published in JAMA online, October 29, 2025. The DOI is 10.1001 JAMA.2025.20402.
Okay, so who are we studying here? Because sepsis can be anything from a urinary tract infection on the floor to a patient on 3 pressors and dialysis.
This is the crucial distinction. These are adults with septic shock.
Yeah.
But they used a very, very rigorous definition. You had to have a suspected or confirmed infection. Okay, that's standard.
Sure.
A lactate greater than or equal to 2.0 millimoles per liter.
Also pretty standard these days.
Right. But here's the key part. You had to require norepinephrine to maintain a mean arterial pressure, or MAP, of 65 millimeters of mercury after you'd already received a fluid load of at least 1,000 millimoles.
So these aren't the patients who just needed a liter of fluids and they perked right up. These are patients who have definitively failed volume resuscitation. They are vasopressor dependent.
Exactly. They're in established fluid refractory shock. And the study recruited them very quickly, within 4 hours of meeting those criteria.
4 hours. So we're really looking at that early critical window of resuscitation.
That's where the decisions we make have the biggest impact. The first few hours really set the trajectory for the patient's entire ICU stay.
Okay, and where did this all happen? Was it one country, one system?
No, and this is one of its greatest strengths. This was a massive global effort. We're talking 86 intensive care units across 19 countries, Americas, Europe, Asia.
Wow.
It gives the study a lot of external validity because it's not just, one fancy academic center doing things their specific way.
That's huge because so often we see these trials come out of a single, highly specialized center, and we're left wondering, does this actually apply to my community hospital? But 86 centers, that's real-world variety.
It is. It represents a huge range of practice patterns and patient populations. And they enrolled 1,501 patients, with 1,467 ultimately included in the primary analysis. For an ICU trial, that is a very robust sample size.
Okay, so we have the who and the where. What about the what? What was the finish line? What was the primary outcome?
The primary outcome was something called a hierarchical composite.
I love that phrase, hierarchical composite. It
Hmm.
sounds incredibly fancy. Break that down for us. What does that actually mean?
It's basically a way to capture benefit that goes beyond just the simple binary of did they live or did they die.
Okay.
Think of it like a tournament with tiebreakers. The analysis compares every single patient in the intervention group against every single patient in the usual care group in a head-to-head matchup.
One-on-one.
Exactly. And the first thing they look at, the most important tier in the hierarchy, is all-cause mortality within 28 days. Did the patient live or die? That's tier 1.
Okay, so survival is king. That makes sense.
Right. If one patient died and the other one lived, the survivor wins that matchup. End of story for that pair.
But what if they both live? Or what if they both die?
That's where the tiebreakers come in. If both patients survived or both patients died, they move to the second tier, duration of vital support.
Vital support meaning what exactly?
How long were they stuck on vasopressors, mechanical ventilation, or kidney replacement therapy? Essentially, how long were they tethered to a life-sustaining machine?
Yep.
The patient with fewer days on support wins.
And if that's also a tie, say they both were on pressors for 3 days and the vent for 5.
Unlikely, but possible. If that was also a tie, they move to the final third tier. Length of hospital stay truncated at 28 days.
So they crunch all these wins, losses, and ties, and they calculate a win ratio.
Precisely. A win ratio greater than 1.0 means the intervention group had more wins across this hierarchy than the control group. It's a more nuanced way of looking at patient-centered outcomes.
I actually really like that composite because, sometimes in critical care we save the life, but the patient spends 3 weeks intubated, gets a track, develops profound ICU weakness, and has a terrible quality of life.
Absolutely.
Getting off the vent a few days faster is a genuine, tangible, patient-centered win. It's not just a number.
It absolutely is. It reflects the efficiency and the quality of the survival, not just the mere presence of a pulse at day 28.
Yeah.
It's a much more holistic view of recovery.
Before we dive into the protocol itself, which is fascinatingly complex, I want to just step back for a second. Why this matters? Why are we so obsessed with capillary refill time right now? I feel like 10 years ago, nobody talked about CRT in adults. It was a pediatric thing.
You're absolutely right. For a long, long time, CRT was ignored, even dismissed in adult medicine. We relied on what we call macrohemodynamics.
Blood pressure, heart rate, CVP, the big numbers on the monitor.
The big, easy-to-read numbers. Or we relied on metabolic markers, most famously lactate.
But lactate, as we kind of hinted at, has its issues.
Lactate is really the Achilles heel of resuscitation guidance because it's a lagging indicator. I like to think of it like looking at a star in the night sky.
Okay.
You are seeing light that left that star years, maybe hundreds of years ago. The star might not even be there anymore. Lactate is similar. It's a signal of a past event. It takes time for the liver to clear it, for it to wash out of the tissues.
So if I fix your perfusion right now, if I open the floodgates and oxygenate your cells this very minute, your lactate might stay stubbornly high for another 2 or 3 hours.
Exactly. And that is the danger zone. Because if I am using lactate to guide my therapy, I see it's high, so I give more fluid. An hour later, I recheck, it's still high, so I give more fluid. By the time the lactate actually drops, I might have overloaded you by 3 or 4 liters.
We call that iatrogenic saltwater drowning.
We do, and we have mountains of data now showing that fluid overload kills. It causes pulmonary edema, tissue edema, acute kidney injury, abdominal compartment syndrome. It's poison.
So there has been this desperate search for a real-time marker of perfusion, something that changes instantly when perfusion improves.
Something that gives you immediate feedback on your intervention.
Enter the CRT.
Enter the CRT. It assesses the periphery, the skin. In shock, the body is smart, it's economical, it shunts blood away from the non-essential organs like the skin to save the brain and the heart. So the skin is the first thing to shut down.
And crucially, the first thing to wake back up.
That's the theory, and the data supports it. It's the canary in the coal mine. Studies show that CRT changes very, very fast within minutes of a successful intervention. If you give a fluid bolus and the stroke volume goes up, the fingertip pinks up almost immediately.
So it allows for a much tighter feedback loop. I do something, I check, I see a result.
Right. It's a do-check-do cycle measured in minutes, not hours.
Now, the original ANDROMEDA-SHOCK trial, the first one, compared CR2 targeting directly to lactate targeting.
And it was a total heartbreaker of a trial. The CRT group had lower mortality, it was around 34% versus 43%, but the p-value was 0.06. It just missed statistical significance.
The dreaded almost trial.
It was the almost trial. But the signal was so strong, the CRT group got less fluid, they had better organ function scores, that the investigators felt they had to launch ANDROMEDA-SHOCK 2 to definitively answer the question. But this time, they didn't just say target CRT. They built a Ferrari of a protocol around it.
Let's pop the hood on that Ferrari. Let's dive into that protocol, because this isn't just poke the finger. This is the methods deep dive.
Right. Okay, let's put ourselves in the shoes of the clinician. You are the doctor in the intervention group. You have a patient who meets the criteria for septic shock.
Okay, I'm at the bedside. What's step one?
Step one, the assessment. You measure the CRT, but you have to be rigorous about it. They used a standardized technique. You apply firm pressure to the distal phalanx, the tip of the finger, using a glass microscope slide.
A glass slide? Why a glass slide? That seems so specific.
It's all about standardization. It provides a flat, clear surface, and it ensures you apply enough pressure. You press until the skin under the glass is completely blanched, totally white. You hold that for 10 seconds. Then you release, and you time the return of normal color. The cutoff for normal is 3 seconds or less.
Okay, so let's say I do that. It's 2 seconds. It's normal. What do I do?
Then you do nothing.
Nothing. That feels so wrong in the ICU.
It's the hardest thing to do. But that's what the protocol says. You monitor them. You come back and check again in an hour. But you do not give fluid just because the lactate is high. You do not crank the pressors just because you're nervous. You accept that, at this moment, peripheral perfusion is adequate.
This is the prevention of over-resuscitation part of the protocol.
That's maybe its most powerful function. It gives clinicians permission to stop.
I love that. It's the clinical application of don't just do something, stand there.
Precisely. If the perfusion is good, leave the patient alone and let them heal.
Okay, but let's take the other road. I check it. It takes 5, maybe 6 seconds. The patient is clamped down. Perfusion is bad. What now?
Now you enter the algorithm. It's a 6-hour intensive loop with 2 tiers of intervention. Tier 1 is all about optimizing the basics. You look at 2 specific numbers on the arterial line, pulse pressure and diastolic arterial pressure.
Pulse pressure, just to remind everyone, that's systolic minus diastolic. So if my blood pressure is 100/60, my pulse pressure is 40.
Exactly. If your pulse pressure is narrow, the protocol defined that as less than 40 millimeters of mercury. The algorithm says this might be a stroke volume problem. The tank might be low.
Might be.
So you don't just give fluid, you check fluid responsiveness.
Note the wording there. Check responsiveness, not give fluids. This is a huge departure from standard care.
It's a crucial distinction. They use things like passive leg raises or mini fluid challenges. If and only if the patient is shown to be fluid responsive, you give a 500 millimole bolus of crystalloid or colloid. Then you go back and recheck CRT.
Okay. What if the pulse pressure is fine, it's wide, say 50, but the CRT is still bad?
Then the protocol directs your attention to the diastolic arterial pressure, the DAP. If the DAP is low, and they define low as less than 50, they instructed clinicians to titrate norepinephrine with the specific goal of getting that diastolic pressure above 50.
Wait, hold on. This is where I have to stop you because this is weird. In standard practice, for decades, we'd titrate norepinephrine to a MAP of 65. I have never heard of titrating to a diastolic target. Why DAP? What's the thinking there?
This is one of the most unique and, I think, physiologically fascinating parts of this entire study. Think about how the heart feeds itself. The coronary arteries, which supply blood to the heart muscle, fill during diastole, when the aortic valve is closed and the heart is relaxed.
Right. Coronary perfusion happens in diastole.
And the driving pressure for that perfusion is your diastolic blood pressure. If your DAP is 35 or 40, which we see all the time in vasodilatory septic shock, your coronary perfusion pressure is practically 0. Even if your systolic is 100 and your MAP is technically 60, your heart muscle is starving for oxygen.
So the engine is running out of gas while it's trying to run a marathon.
Precisely. The theory is that by prioritizing that diastolic floor, by getting the DAP above 50, you are protecting the heart from ongoing ischemic injury. You improve the pump's own function, which then improves global perfusion downstream.
That is fascinating. It's so elegant. So tier 1 is check and fix the tank if pulse pressure is low, or check and fix the perfusion pressure, specifically the diastolic if DAP is low.
Correct. A very logical stepwise approach. And if you do those things, you come back in an hour and the CRT is still abnormal, then you move to tier 2.
This is where it gets fancy, I'm guessing.
This is where we bring in the heavy artillery. Tier 2 mandates a bedside echocardiogram, point-of-care ultrasound. You have to look for cardiac dysfunction. Is there severe left or right ventricular failure?
And if you see it, if the heart's barely squeezing,
Then you treat it specifically. Maybe you add an inotrope like dobutamine. Maybe you need to adjust the PEEP on the ventilator to help the right ventricle. You tailor the therapy to the specific cardiac problem you just identified.
makes sense. But what if the heart looks fine on the echo? Good squeeze, no major issues.
Then you cycle back through some other ideas. First, you recheck fluid responsiveness. Maybe things have changed. If they're responsive, you can try more fluid. If not, and the CRT is still bad, you move to a series of tests.
A test? What do you mean?
They employed a strategy of challenge and response. First, if the patient has a known history of chronic hypertension, you perform a MAP challenge. You crank the norepinephrine to target a MAP of 80 to 85 for 1 hour.
Why would you do that?
Because a patient with chronic hypertension might have shifted their autoregulation curve. Their normal blood pressure might be 160/90. So for them, a MAP of 65 might actually be a state of relative hypotension.
So for them, 65 isn't enough to perfuse their kidneys.
Exactly. So you test it. You push the MAP up and see what happens to the CRT. Does it improve? If yes, great, you found your target. If no, you go back down. No harm done.
It's basically a 1-hour trial period. Does this patient like high blood pressure? I love how personalized that is.
It's the definition of personalized medicine. And if even that fails, the final step in the algorithm is the inodilator test. You start a fixed low dose of dobutamine, 5 micrograms per kilogram per minute, even if the echo looked normal.
Wait a minute. You're giving dobutamine a heart squeezer that also vasodilates to a patient who doesn't have obvious heart failure on their echo? Why?
Yes. This is a controversial but really interesting step. The theory is that severe sepsis can cause an occult cardiomyopathy, or, more likely, a severe microvascular sluggishness. Dobutamine, through its beta-2 effects, can help recruit capillaries and improve blood flow at the tissue level, independent of its effect on the heart muscle itself.
So you're not just treating the pump, you're trying to treat the pipes at the very end of the line.
That's a great way to put it. And again, it's a test. You try it for an hour. If the CRT gets better, you keep it on. If not, you turn it off.
Wow. So it's a very, very structured logic tree. Is it volume? Is it pressure? Is it the pump? Is it the microvasculature? And you only move to the next step if the CRT stubbornly stays bad.
Precisely. It breaks the fluid pressor tap cycle that so many of us fall into. It inserts thinking and physiology back into the loop.
So what did the usual care group get? Was it a free-for-all?
Pretty much. They got standard care based on the Surviving Sepsis campaign guidelines. Clinicians could use fluids, pressors, echoes, inotropes, whatever they wanted to, but they were not mandated to follow this algorithm.
And they weren't targeting CRT?
No. CRT was only measured at baseline and then again at 6 hours for data collection.
Yeah.
It was not used to guide any therapy.
Okay. So we have a rigorous, hands-on, hourly protocol versus do what you usually do. 1,467 patients. And it was unblinded because obviously the doctors knew if they were the ones using the glass slide and the algorithm.
Yes, and that unblinded nature is a major limitation we have to keep in mind as we look at the results. It absolutely introduces the risk of performance bias. If I know my patient is in the special group, maybe I just pay more attention to them. Maybe I'm more aggressive about weaning their sedation or their ventilator settings.
Or maybe you're more confident in stopping fluids because the protocol has your back. It gives you permission.
Exactly. That's a huge potential confounder.
All right, the moment of truth. Let's get to it. The results. Did the glass slide save the world?
It didn't save the world, but it did win the game. The primary outcome, that hierarchical composite we talked about, was statistically significant in favor of the intervention group. The win ratio was 1.1 seen.
Okay, unpack that win ratio for us again. 1.16. What does that number mean?
A ratio of 1.0 would mean no difference. 1.16 means that the intervention group had 16% more favorable outcomes, or wins, compared to the usual care group when you look across that whole hierarchy of death, organ support, and length of stay.
That sounds good. That sounds like a win. But where did the wins come from? Was it the most important tier? Did they survive more?
This is the absolute crucial point. And if you take one thing away from our deep dive today, let it be this distinction. There was no significant difference in 28-day mortality.
None.
None. 26.5% of patients died in the intervention group. 26.6% of patients died in the usual care group.
It was identical.
It was virtually identical. The hazard ratio was 0.99. So to be crystal clear, the protocol does not save more lives.
So the wins that gave them that positive primary outcome must have come from the tiebreakers.
Exactly. The wins were driven almost entirely by the second tier of the hierarchy, duration of vital support. The intervention group got off vasopressors and ventilators significantly faster than the usual care group.
Okay, how much faster are we talking?
The best way to look at it is a related secondary outcome, organ support-free days. The intervention group had a mean of 16.5 days alive and free of machines, compared to 15.4 days in the usual care group.
So a difference of about 1 day, 1.1 days.
Correct. On average, patients in the CRT group got about 1 extra day alive and free of life support within that first month.
Now, the cynic in me, and you know I have one, says 1 day. Who cares about 1 day? That doesn't sound like a revolution.
Yeah, I get that. But in the world of the ICU, 1 full day off vasopressors and ventilators is actually massive. It's truly a big deal.
Make the case. Why is it massive?
1 day less on a ventilator means 1 day less of heavy sedation. That means less risk of ventilator-associated pneumonia, less ICU delirium, which is a huge driver of long-term cognitive problems. It means the patient can get out of bed and start physical therapy sooner, which prevents ICU-acquired weakness.
And from a hospital or system perspective?
It frees up a critical care bed 24 hours earlier. In a world of perpetual ICU bed shortages, that is an enormous benefit. It improves patient flow for the entire hospital.
That's a fair point. If I'm the patient or the patient's family, I definitely want to be off the breathing tube a day earlier. So the question is why? What happened physiologically that made them recover faster?
This is where the process measures in the study tell a fascinating story. First, and maybe most importantly, the intervention group received significantly less fluid.
How much less are we talking about?
Over that initial 6-hour resuscitation period, the intervention group got a mean of roughly 595 ml, while the usual care group got about 847 ml.
So the difference of about 250 milliliter.
Honestly, that seems small. That's a cup of coffee.
It does seem small when you look at the mean. But you have to remember that's the average of everyone. Where the protocol really shines is in the subgroups. For example, look at the patients who had a normal CRT at baseline.
The ones who are already perfusing well? Yes. In the usual care group, those patients still got fluid just in case, about 440 milliliters on average. In the intervention group, because the protocol said stop, they got almost nothing, about 210 milliliters.
So the protocol acted as a brake. It prevented that reflexive just-in-case liter of fluid.
Exactly. It empowered doctors to say stop, and that likely prevented a lot of fluid overload in a key subset of patients.
And on the flip side of the coin, what did they get more of?
They got significantly more dobutamine. 12.3% of the intervention patients received dobutamine, compared to only 5.3% in the usual care group.
That's more than double the amount.
It is. The protocol, by forcing clinicians to use echo and consider the inodilator test, uncovered cardiac dysfunction and microvascular issues that were being missed in the usual care arm.
So in usual care, clinicians might have just kept pushing more fluids or more norepinephrine when what the patient really needed was some inotropy.
That's exactly what the data suggests. The protocol uncovered these hidden physiological problems that responded to inotropes.
So let me see if I have this right. By using this algorithm, they gave less salt water and more heart squeeze medicine.
That's a good summary.
Uh-huh.
And that combination led to faster CRT normalization. At the end of the 6-hour protocol, almost 86% of the patients in the intervention group had a normal CRT versus only 62% in the usual care group.
That is a huge gap. That proves that the protocol actually worked to fix the target it was aimed at.
Exactly. It shows the intervention was physiologically effective. They fixed the peripheral perfusion faster. And because the perfusion was fixed, they could wean off the norepinephrine faster, which is why they had more organ support-free days.
And what about lactate? Did the metabolic signal line up with this clinical signal?
It did. Lactate was also significantly lower in the intervention group at 6 hours. Not by a huge amount, 3.2 versus 3.5, but it was statistically significant and moved in the right direction.
Okay, let's talk about safety. Because giving more dobutamine, which can cause arrhythmias, and restricting fluids, were there any bad outcomes, any safety signals?
They reported 5 suspected unexpected serious adverse reactions in the trial, but after review, none were deemed to be related to the study protocol. So, based on the data presented, The protocol appears to be safe.
So to summarize the results, we have a positive trial based on the win ratio, but a neutral trial for the outcome that everyone really cares about, which is mortality.
Correct. And that is where the interpretation gets tricky and where the debates in the journals and at conferences will happen. If you are a purist who only cares about 28-day mortality, you might look at this and say this is a negative trial.
Right.
But if you care about the efficiency of care, reducing morbidity, getting patients out of the ICU and back to their families faster, this is a very positive result.
Let's move to clinical translation. Let's make this practical. Who is this for? Did any specific type of patient benefit more than others?
It's a great question. The visual abstract that was published with the paper has a subgroup chart that hints that patients with higher severity of illness scores, specifically SOFA scores, greater than or equal to 10, might have had a stronger signal for benefit.
The sicker patients did better.
It looked that way visually. However, the text of the paper itself explicitly states there was no effect modification for the subgroups assessed. So statistically, we have to conclude that the benefit was consistent across the board.
So no difference based on age, initial lactate levels, or the source of sepsis, like pneumonia versus a UTI.
Based on their formal statistical analysis, no. The principles of the protocol seem to hold true for the broad population of septic shock patients.
So I can apply this thinking to my 40-year-old with urosepsis just as much as my 80-year-old with pneumonia and multiple comorbidities.
Based on the data we have, yes.
So how do I actually use this tomorrow? I work in a busy unit. I don't have a research nurse to come around every hour with a glass slide and a clipboard. Is this truly practical?
That is the million-dollar question. It's the external validity issue. This protocol, as written, is labor-intensive. There's no doubt about it. It requires hourly assessment. It requires you to be proficient in checking pulse pressure, in assessing fluid responsiveness, and in doing basic point-of-care echo.
That's a high bar for some places.
It is. But the concept isn't hard, right? The mindset is very portable, even if the strict protocol isn't. You don't need to follow the 6-hour algorithm to the letter to adopt the deresuscitation mindset.
Talk to me more about that, the deresuscitation mindset.
The single biggest takeaway for me is the normal CRT pathway. If you walk into a room, the patient is on norepinephrine, their lactate from an hour ago is 3, but you press on their finger and their CRT is 2 seconds. Do not give more fluid.
Resist the urge. Resist the lactate.
Resist the urge to treat the lactate with fluid. The peripheral perfusion is good. The lactate will clear on its own time. Just wait. That single action, repeated across the hospital, would prevent an immense amount of iatrogenic fluid overload.
And on the other side, if the CRT is bad, if it's 5 seconds...
Then don't just reach for the fluid bag blindly. That's the other key lesson. Look deeper. Look at the pulse pressure. If it's wide greater than 40 fluid, probably won't help because their stroke volume is likely already adequate.
So look somewhere else.
Look somewhere else. Look at the DAP. Is it 45? Maybe they just need more pressure to perfuse their own heart. Look at the heart itself with a quick echo. Is it barely moving? Maybe they need butamine.
It forces you to be a physiologist again, not just a robot following a bundle.
Exactly.
Yeah.
It breaks the autopilot. It makes you think.
I want to circle back to that diastolic pressure target one more time. DAP greater than 50. That feels like something I can do right now, tonight, on my next shift.
It is.
Okay.
It's a very actionable piece of the protocol, and it makes so much physiological sense. But I do have to add a major caveat. This study did not test a DAP target in isolation.
Right.
It tested the whole bundle. We don't know for sure if the benefit came from the DAP target or the fluid restriction or the increased use of dobutamine or the CRT checks themselves. It's a bundle effect.
We don't know which ingredient made the cake taste good, just that the whole cake was better than the standard one.
That's a perfect analogy. But purely from a safety and plausibility perspective, keeping the diastolic pressure above 50 to ensure coronary perfusion seems like a very reasonable and low-risk thing to do.
Let's play devil's advocate for a minute. What are the limitations? We've touched on some, but let's really dig in. Why should I be skeptical of these results?
Number one, and we have to keep hammering this, is the unblinded design. That is the biggest one. The win for the primary outcome was driven by getting off vasopressors and ventilators faster.
Which are subjective decisions.
They are entirely subjective decisions made by the treating clinician. If I'm the doctor and I know my patient is in the personalized group and I see their CRT is normal, I might feel much safer and more confident turning off the Levophed earlier.
Whereas in the usual care group, without that data point, I might just leave it on for another few hours just to be safe.
Precisely. So the intervention itself The knowledge of the CRT might have encouraged the very behavior that led to the positive primary outcome. It's a potential self-fulfilling prophecy.
But isn't that the point? If the CRT gave them the confidence to wean and the patients tolerated it, they didn't crash or need to be reintubated, then the weaning must have been appropriate.
That is the counter-argument, and it's a very strong one. If it was just bias leading to premature weaning, you'd expect to see more rebound events, more patients needing to go back on pressors or be reintubated. And we didn't see that. So the bias, if it existed, might have simply facilitated better, more timely care.
What's another limitation?
Subjectivity of the measurement itself. Pressing on a finger is an art. They did a fantastic job trying to standardize it with the glass slide and training videos. But in the real world, without a research coordinator, without the glass slide, is my 3 seconds the same as your 3 seconds?
Probably not. And what about other factors?
Exactly. Lighting conditions, the patient's core temperature, ambient room temperature, even skin pigmentation can all affect CRT. They tried to account for this, but it remains a limitation of the tool compared to a cold, hard digital number on a screen.
And finally, the complexity.
Yes, 86 centers did this, which is amazing. But these were highly motivated, likely academic or academic-affiliated centers. Can a small community ED with 1 doctor and 2 nurses replicate this intensive hourly monitoring protocol with pulse pressure checks and echo? Maybe not. The external validity is a real question.
But they can definitely press a finger.
You can definitely press a finger, and that's the part that's infinitely scalable.
Okay, we're coming up on time. Let's try to wrap this all up. This is a dense, important study. Give me the 3 big takeaways from ANDROMEDA-SHOCK 2.
Okay. Takeaway number 1. What was tested? They tested a highly structured, personalized hemodynamic resuscitation, or PHR, protocol. The key feature was that it used capillary refill time, CRT, to guide all decisions on fluids, pressors, and inotropes in the first 6 hours of septic shock.
Takeaway number 2, the big result.
What was found? The CRT protocol was superior to usual care on the primary composite outcome, with a win ratio of 1.1 seen. This superiority was driven almost entirely by patients getting off vasopressors and mechanical ventilators faster. Crucially, there was no difference in 28-day mortality.
And takeaway number 3, the one we take to the bedside.
What changes tomorrow? This study empowers you to stop treating numbers and start treating perfusion. If a patient's CRT is normal, you now have high-quality evidence to hold the fluids even if the lactate is still high. And if the CRT is abnormal, it's a signal to look deeper. Check pulse pressure, check diastolic pressure, look at the heart with ultrasound before you reflexively hang another bag of saline.
So use the CRT as a stop sign for fluids and as a go sign for investigating physiology.
That's a perfect way to put it.
This has been a fascinating look at how a simple, no-cost bedside physical exam finding, when combined with some real physiological discipline, might be better than our high-tech, expensive, and often delayed markers. It really puts the thinking doctor back in the driver's seat.
It does. Stay curious. Look at your patient.
If you found this helpful, share with a colleague, subscribe so you don't miss next week's study.